Okay, sorry about that. I'm going to continue on with where we left off, which was we were talking about the urinary system. So let me share my screen with you. And okay, here we go. So we know that UTIs are a risk factor because of the catheterizations and also retention. Also, mom has some trauma possibly from a vaginal delivery. So you already know the signs and symptoms of a UTI: burning with frequency and pain, maybe some foul smell to the urine, and maybe some blood in the urine as well. And then retention, just from opioids, trauma, anesthesia, all of those things can cause urinary retention. So we need to make sure that mom is voiding every 2 hours, like I mentioned, so we can allow for the uterus contract and also prevent urinary retention, which could cause a UTI. If she's unable to void on her own because of the retention, then we need to perform either a straight cath or fully catheterization. You do need to know these vaccines. Okay. Remember, rubella is a what? Live vaccine. So she should not get pregnant for 1 month following that immunization. So that's really important to know. We give those to moms who are rubella non-immune. Another important one here is the RhoGAM, which I already discussed, within 72 hours. Varicella, that's not like necessarily a common one we give after birth, but if she needs it, it is another live vaccine. So she cannot get pregnant for 1 month following the immunization. And then, of course, the Tdap, like I mentioned, that is safe to give during pregnancy or after. So that helps prevent the pertussis in babies. Mostly that's why we give it, to help protect the babies. Let's see here. That's that chapter. As far as baby-friendly care, remember these phases of maternal role: attainment, taking in, being very dependent, taking hold, kind of that dependent, independent, and then letting go, going back to interdependent, assuming her normal roles. So do understand these in the time frames. Dependence, the first 24 to 48 hours. The second one can last 10 days to several weeks. And then finally, we resume our normal roles. We've kind of adapted as a family. Do know the signs of bonding. So, interacting with the baby, eye contact, caring for the baby's needs, smiling, talking to the infant, things like that are going to be really important to pick up on. And then also know the signs of um, lack of bonding. So turning away from the infant, handling the infant roughly, not including the infant in family context. Those types of things are a concern and a red flag right there. So do know those. So discharge teaching, we already talked about perinatal care, and we talked about breast care, what she can do to help with that. So I do need you to know that, all of those things, as far as lactating versus non-lactating, how to care for breasts, and then also perinatal care, which we talked about. Activity, remember pelvic rest, no driving, those things you guys mentioned in class when we were doing our case studies, no heavy lifting, so only the infant, no other children. They should try to prevent DVTs by avoiding prolonged periods of legs crossed, limit stair climbing. Nutrition, oops. She should keep taking her prenatal vitamins for 6 weeks. If she's nursing, she should continue those throughout nursing. Drink lots of water. And then, of course, the recommended calorie intake. I always say 500 if they're lactating. Let's see. These are warning signs or danger signs when to call the doctor. So know all of those. Fever, changes in vaginal discharge. So if it's heavy, clots, foul odor, looking for signs of incisional infection, so episiotomy or incisional pain, abdominal pain, pain in the breast, signs of a DVT, of course, urinary issues like UTIs. And then we talked a lot about depression in class, remember, cannot provide self or infant care. So baby blues is self-limiting, will go away on its own. Depression does require intervention. So she could do, medications, counseling, it does require intervention from her provider. Oops, disorders, DVTs. I'm not going to spend a lot of time on that. You've kind of got that a lot with your, I'm sure, fundamentals in med-surg, but how to prevent them: early ambulation. We know who's at risk, especially if she's at a C-section or an operative vaginal birth, anything that's going to inhibit her mobility. smoking, if she has a history of thromboembolism, older age, multiparity, diabetes. Okay, remember, do not massage any affected limb if there is signs and symptoms of a DVT. We can treat with blood thinners, heparin, Coumadin. Let's see here. Pulmonary embolus. So when we were discussing labor, remember an embolus, what kinds of signs and symptoms is somebody going to have with an embolus? Well, it's going to go the long, right? So apprehension, chest pain, dyspnea, tachypnea, diaphoresis, coughing up blood, distended neck veins, hypoxia, hypotension, all those things. So they could even go into just complete arrest. So this is emergent care here. Put them in a semi-Fowler's position, give them oxygen, call for help. If it is a DVT, they may need some thrombolytic therapy and some coagulopathies that they could develop, ITP, where their platelets get really low, or DIC, where their clotting and anti-clotting mechanisms are off. So basically they're clotting in their microvasculature, leaving their larger vessels not able to clot. So a client in DIC, there's a lot of risk factors for it, and patients can go into DIC for reasons outside of OB, but in OB, here are some of the things that can cause DIC. So really, if she's had a complication, it can cause this complication. So if somebody has a placental abruption, remember where the placenta rips away from the uterine wall, that can lead to DIC. If she had an amniotic fluid embolism, so all these horrible things, now we lead to DIC. DIC is treated in the ICU. You will learn about this in complex if you haven't already. My main focus with DIC is for you to recognize it, okay? Because if you see it in OB, they're not going to stay on your floor. They're going to go to ICU, but you have to be able to recognize it with your assessment. If a mom is bleeding, and I'm not talking lochia, bleeding, I'm talking bleeding from everywhere. Nosebleeds, bleeding out of her incision, IV sites, oozing blood, hematuria, petechiae, lots of bruising. Those are all signs and symptoms of DIC. I've only seen it a handful of times in my career, but I remember one in particular. The mom had a C-section and her incision just kept oozing and oozing and oozing. I kept putting pressure dressings on and it kept oozing and oozing. So that was a warning sign to me. The mom ended up going to ICU. She did have, in fact, DIC. Postpartum hemorrhage. Here's our risk factors. Uterine atony. Uterine atony is the #1 cause of postpartum hemorrhage. So that's a boggy uterus. What are the things that can cause uterine atony? Full bladder, maybe a prolonged labor if she's on mag sulfate, because remember mag sulfate relaxes the uterus. So uterine atony is the #1 cause, okay? Retained placenta fragments, anything that doesn't allow that uterus to contract can cause uterine atony, all right? Other things that can cause hemorrhage, remember I said in class, if she has a really firm uterus and she keeps bleeding, think lacerations, could be cervical laceration. Another thing is hematoma. We're not going to actually see bleeding, but remember she'll feel that pressure in her perineal area. Those are all things that can cause hemorrhage, but uterine atony is #1. First thing we do, if mom bleeds, we check the pads and we massage the fundus. If we see a large amount of bleeding, start massaging that fundus. Stay with your patient, call for help. Any type of blood loss. Remember, we need a large bore IV catheter. We need oxygen via non-rebreather, 10 to 12 liters. We need type and screen, type and cross. We need fluid bolus. So if she has one line in, get another line in because we're going to need to fluid bolus. We're also going to need to think blood transfusion. Okay, all those things that we did in our simulation. Weigh the pads. So you want to get your QBL by weighing those pads. Lay the mom's head down, right? Probably you're going to have some labs to draw, hemoglobin, hematocrit. They're going to want to know what her baselines were. We're going to need to get frequent vital signs. And then, of course, our medications. You do need to know these. Okay, so if you don't know them, please know them. If she has bladder distension, of course, we need to get that urine out of that bladder. So if that is the culprit for uterine atony, get a Foley catheter in her. All right. Here's all of those things that we need to do. Oxytocin is #1. Usually line of defense, if we can give it IV, so it's very rapid. We can also give it IM. Okay, so think oxytocin can be given IV or IM, and you can give all 4 of these in a hemorrhage situation. Methylgonabine is a uterine stimulant. Again, contracts the uterus. It's given IM. Noted, do not administer to clients who have hypertension. It can cause them to go into hypertensive crisis. So if the mom is hypertensive, this is not one that you're going to want to give because then you're going to have two problems. Misoprostol, again, this is Cytotec or misoprostol, Cytotec subtraining. We can give this rectally, 800 micrograms. You can also give it PO, but the rectal route is way quicker, way faster absorbent. And then finally, carbaprost, again, a uterine stimulant. You can give this IM. You need to make sure you do not give this one to a patient with a history of asthma. Okay, so two contraindications. Carbaprost, do not give to somebody with asthma. Methylgonabine, do not give to somebody with hypertension. You do need to remember those. Those are two very common ailments in adults, asthma and hypertension. So we need to make sure that we don't give those medications if the mom has a history of that. That's why it's really important for the primary nurse to stay with the patient, because the helpers that respond to the hemorrhage may not know their history. The primary nurse will. So that's up to you as a primary nurse to say, hey, here's our client. She's bleeding. We do have this history. So it's really, really super, super important. Okay. Massage of fundus, all of those things you need to do for blood loss, and then your drugs. Okay. You may need to fix the cause. Why is the uterus boggy? Do we need to insert a catheter? Is it a urinary retention issue? Do we need to get rid of some of those placental fragments? Is it a placental fragment issue? What is going on? So sometimes we have to fix those things before we can really fix the hemorrhage, if that makes sense. Again, think outside the box. If her uterus is firm, do we have a hematoma? Do we have a laceration? And like I said, those hematomas can sneak up on you. They, bleed quite a bit, and then finally they'll start feeling that pressure. They can lose quite a bit of blood before they start feeling that pressure. So in recovery, especially that stage 4, remember, the closer to delivery they are, the more risk they are for blood loss. Watch your vital signs. Watch that trend. Watch for that pulse to creep up. Watch that blood pressure creep down. If you see that trend ever, and I don't care if it's OB or not, if you have a post-surgical patient or any patient at risk of bleeding, watch that trend, because that is always one that should shoot red flags up in your head. Okay. Talked about subinvolution. So infection and retained fragments can cause that uterus to subinvolute or go above the umbilicus. Remember, 1U, 2U. So again, we need to fix the cause with that. Inversion of the uterus, main thing. Support the base of the uterus when you're massaging, because if you're doing vigorous massage on a mom that's hemorrhaging, you could invert a uterus. So see, vigorous fundal pressure. Support that base, because inversion will cause even more hemorrhage. Okay. Retained placenta, like I said, that can cause two things: hemorrhage and infection. So be on the lookout for signs and symptoms of infection. And then hemorrhage, always think what it could be. It could be a retained placenta. If there are pieces left in there when we're doing all of our things, that's what we call the provider. The provider either has to do a manual removal. Remember, like I said, have some have some fentanyl or something for that patient, because it is going to hurt. They literally are elbows deep in that patient trying to pull out some of that placenta. And then worst case scenario, they could insert a Bakri balloon once they get that placenta out, or if mom's hemorrhaging, they may need to go to the OR. And worst case scenario, complete hysterectomy. And we talked lacerations and hematomas. Those would have to be repaired. Hematomas would have to be evacuated. That would be a surgery. Okay. Let's see. Finally, our last chapter, we did this in class. You do need to know these 4 infections: endometritis, mastitis, wound infections, and then of course UTI. Endometritis is an infection of the uterine lining. So again, that's where you're going to have, all of these are going to have fever. With this one, endometritis, you're going to have abdominal pain, because where's that infection? In the abdomen, inside the uterus. So that uterus is going to be very tender, very, very tender. Mom's going to spike a fever, and then the lochia is going to have a foul odor to it. So those things are going to indicate endometritis. Remember, mastitis, breast infection. It's going to be unilateral, meaning one side. That breast is going to be red, very, very tender, and may even have streaks of red going to it. Okay. Mom was also going to spike fevers. They've the one, usually in acute care, they're gone before these infections set in. However, if you have a C-section that's been there 3 or 4 days, I've seen them set in, they spike very high fevers, high and fast. I mean, 103s, sometimes 104s. So IV antibiotics is a must for these types of things if they get that severe. Okay. With wound infections, you guys know that. So whether it's an episiotomy or an incision from a C-section, redness, drainage, swelling, and of course fever. They could eventually, with a wound infection, dehiss or eviscerate, so we want to prevent that from happening. And then UTIs, of course, we already talked about. You're going to want to do some lab tests looking for leukocytosis, increased elevated white blood cells, right? In frequent vital signs, again, assessing all of our bubble assessment. We're going to use asepsis, depending on type of infection, how we're going to treat. You know, it's usually a broad spectrum antibiotic. With mastitis, remember we can use ice packs. Mom may need to pump, especially if it's very, very painful, or manual express breast milk, but it is safe for her to let the baby nurse and get her breast milk. So that is totally fine. She should wear a well-fitting bra. There's your UTI there, which we already discussed. So plenty of fluids, perineal hygiene, all those things. So know those 4 infections. And that is postpartum for you. I'm still working on building the exam. Oh, sorry, forgot about postpartum depression, which we already talked about. The difference between baby blues, depression, and then of course psychosis, where you can get disorientation, confusion, paranoia, delusions, things like that. Our number one concern always, always, always is suicidal ideations and harm towards the baby. So any types of harm towards mom's self or harm towards the baby, including neglect. If mom's neglecting herself or the baby, that is harm. So all of those things are signs and symptoms of that. Antidepressants, of course, are going to be of the essence. Plenty of rest for mom. Identify her support systems. One of the biggest risk factors for this depression is not enough support or a absent support system. So you got to, make sure you're helping her identify who her supports are. She may even need support groups even that might help, as well as maybe even some meeting with a psychiatrist, and some interdisciplinary care there. But for us in the hospital, it's important for us to identify the red flags while we're there so we can get on it right away. Maybe she has a history of depression and she needs to get started on her medications right away while they're in the hospital. We can do that, for her to maybe help alleviate that from occurring. So I will say for this exam, do your postpartum Jeopardy. Listen to my recorded lectures. Please read your book. Highlight in your areas. I just did with you. Highlight those areas and read them again. Do the questions at the back of the book. And any areas that you're weak in, just read it again. I was always one, I had to read things. Once wasn't enough. I had to read them twice, maybe even 3 times for it to really stick. But the test is over those chapters, those case studies we did in class, the Jeopardy, everything is written to help you be successful on this exam. So reach out to me. I know some of you have. If you have extra questions, we'll take our exam in class again this weekend. We are in clinical this weekend as well. So go to your spots. I will see you guys at 6:45 Saturday, or if you're at OSF, just please report to that area. And any questions you have in the meantime, let me know. And I hope you have a great rest of your week and hope this was helpful.